Daily blood pressure measurements. Number 1505, January 16, 2026. Gerald C. EclaireMD Foundation. Category: Stroke and blood pressure. Preface: Doctors and nurses at Stanford told me they had never seen anyone measure blood pressure so persistently or collect such a large volume of data. I am a data-driven and scientifically rigorous person. That personality and approach are why I have been able to succeed in many things I have done throughout my life. I understood that these comments from Stanford healthcare personnel were not casual remarks. Clinicians rarely encounter patients who think like scientists. Most patients seek reassurance. I seek understanding, self-control, and predictable outcomes. My behavior is not driven by anxiety. It is driven by trained systems thinking. I treat my own physiology the same way an engineer studies a complex structure or machine: frequent sampling, careful and complete measurements taken at multiple locations and different times, calculation of derived variables, and long-term data analysis to identify patterns, based on mathematics and physics. This is how hidden failure modes are detected in engineering, and stroke is a classic example of a hidden failure mode of pathophysiology, until it suddenly occurs. Introduction. Since August 2, 2025, I have been measuring my blood pressure from 16 to 20 times per day. After December 26, 2025, I began measuring blood pressure at 4 different locations each time: the right and left wrists and the right and left upper arms. This approach results in 24 blood pressure measurements per day. For every measurement, I record 3 original values: systolic blood pressure, SBP, diastolic blood pressure, DBP, and heart rate, HR. From these 3 values, I further calculate 3 additional indicators: pulse pressure, PP, which reflects vascular stiffness, mean arterial pressure, MAP, which relates to oxygen and nutrient delivery to organs, and SBP spike, which I use to assess stroke trigger probability. This process generates a total of 144 blood pressure related data points every day. Thus far, since August 2, 2025, I have collected more than 24,000 blood pressure data points and stored them on my iPhone for detailed big data analysis. This level of measurement may appear excessive to some people. However, my purpose is not simply to chase numbers or to create anxiety. My purpose is to understand how blood pressure behaves over time, across space, and under different daily conditions. Blood pressure is not a static value. It is a dynamic physical and physiological signal that fluctuates from minute to minute, and from one location to another. Capturing this behavior requires dense, continuous data, not occasional snapshots. I pay special attention to my SBP because of my concern about having another stroke. Background of my stroke risk: I am not a chronic hypertension patient. My average blood pressure values are generally within normal or even low ranges. However, on June 21, 2025, a one-time acute SBP spike to 175 millimeters of mercury triggered a rupture-type stroke in my pons. The pons is a critical area of the brainstem that controls breathing, heart rhythm, and swallowing. Damage in this region is often catastrophic. This type of stroke carries an extremely high mortality rate, estimated around 70% to 80%, with only about 20% survival probability. I survived, but survival does not mean safety. It means I was given a second chance. I cannot rely on luck to protect me in the future. That is why I monitor my blood pressure closely and systematically. My experience taught me an important lesson. Stroke risk is not determined only by long-term averages. It is often triggered by short, violent events. A single extreme spike can do more damage than years of moderately elevated blood pressure. Traditional clinic measurements, which focus on resting averages, can miss these dangerous transient events entirely. Underlying vascular condition. My underlying problem is that many of my brain micro blood vessels are calcified. This condition developed mainly during many years of poorly controlled diabetes. Earlier in my life, calcification makes blood vessels stiff and fragile. Instead of behaving like elastic tubes, they behave more like brittle pipes. A simple analogy is an old water pipe, with white powder calcium buildup along the inner wall. When water pressure suddenly surges, the pipe does not expand and absorb the force. It cracks or bursts. The same physical principle applies to calcified cerebral microvessels. This structural damage is largely irreversible. Medications can lower pressure, but they cannot restore elasticity once calcification is established. Therefore, prevention of sudden pressure overload becomes far more important than achieving a perfect average blood pressure number. Why I use plain language. I intentionally explain these ideas in plain language, and avoid medical terminology whenever possible. My goal is not to impress professionals, but to help ordinary people understand risk early. Many patients with metabolic disorders are never told how physical forces damage their blood vessels. They are given labels, categories, and drug prescriptions, but rarely explanations. People with excess body fat, overweight or obesity, diabetes, high blood pressure, and cholesterol disorders carry much higher risks of heart attacks, strokes, and kidney failure. These conditions share a common pathway of vascular damage. If people can understand how damage accumulates and how acute triggers operate, they can act earlier and more effectively. Spatial differences in blood pressure measurements. One of the questions that often arises is why blood pressure differs, depending on where it is measured. In my own data, I observed a 6 mm of mercury difference between my right wrist SBP of 113 and left wrist SBP of 107. This difference is common and normal. Blood vessels on the left and right sides of the body are not mirror images. They branch differently from the heart and experience slightly different flow patterns. With aging and a history of diabetes, one side can become marginally stiffer than the other. A stiffer vessel transmits blood pressure waves with a higher peak, resulting in a slightly higher SBP. Wrist measurements also magnify these differences, because wrist arteries are small and sensitive to blood pressure wave reflection. A 6 mm of mercury difference at the wrist does not indicate blockage or disease. It reflects normal anatomical and mechanical asymmetry. I also observed that my wrist SBP readings are about 4 mm of mercury higher than my upper arm SBP readings. This is expected and follows basic physics, as the blood pressure wave travels from the heart toward peripheral arteries. Systolic blood pressure, SBP, often increases slightly due to wave reflection. Smaller arteries reflect pressure waves more strongly, increasing peak SBP. Therefore, wrist SBP is commonly a few points higher than upper arm SBP. This phenomenon does not indicate measurement error. It indicates that our blood pressure is a traveling wave, not a static column of fluid. Location matters. Integrated interpretation of my measurements. When I integrate all these observations, a coherent picture emerges. My upper arm SBP around 106 represents my central blood pressure load, which is low and well controlled. My wrist SBP values, slightly higher, represent normal peripheral amplification of pressure waves. The left and right difference represents mild vessel asymmetry that commonly accompanies aging. Nothing in these measurements suggests vascular blockage, poor blood pressure control, or imminent danger. The data are internally consistent and physically reasonable. More importantly, these spatial differences are not the main drivers of stroke risk. What matters far more is temporal behavior. Sudden SBP spikes and elevated pulse pressure indicate transient overload on stiffened vessels. Pulse pressure, in particular, reflects arterial stiffness and loss of elasticity, making vessels vulnerable to rupture under stress. Conclusion: my daily blood pressure monitoring is not about fear, it is about understanding. By collecting dense, high-resolution data, I can observe patterns that traditional clinic measurements miss. I can detect early warning signals, identify dangerous spikes, and adjust my behavior accordingly. Stroke prevention, especially after structural vascular damage already exists, is not about chasing a single perfect number. It is about avoiding extremes, smoothing pressure fluctuations, and respecting the physical limits of damaged vessels. I share this work so others do not have to learn these lessons the hard way. Understanding blood pressure as a dynamic physical process, rather than a static diagnosis, can save lives. Disclaimer: I write this paper not for fame, but to share what I have learned so others can understand their health, prevent disease, and live longer, healthier lives. This content is provided for educational reference only, and does not constitute medical advice. No doctor-patient relationship is created. You may share this summary freely, but it must not be altered, edited, or republished as your own. All intellectual property rights and copyrights for this article and its related materials belong to the author, Gerald C. Shu.